Hi everybody, my name is Rachel Bodie-Leppeholtz, and today I'll be presenting on the mental health needs of several special populations. The first population I'd like to talk about is the elderly. At least 1 in 4 older adults age 65 or plus is experiencing a mental disorder, including depression, anxiety, dementia. With the aging population, the number of mental health disorders is expected to double. Mental health problems are very common among the elderly populations. Connections with others allow us to thrive, and as we age, our connections with others we used to be close to are more limited than when we were younger. Social isolation is linked to health problems, including the depression and cognitive decline of our older population. Seniors age 85 plus actually have the highest rate of suicide among all the age groups. There's a treatment gap where 2/3 of the seniors with a mental health problem do not get treatment. This may be due to a variety of reasons, but most commonly it goes undiagnosed. Mental health services are extremely limited in this population. There are several different assessments and screenings we can complete to screen for mental health concerns in the elderly. I'm just going to go through a few of them, and some of them are going to end up being repeated. The geriatric depression scale, this is a 2-form scale. One of them is long and has 30 questions, and one of them is short and has 15 questions. The short form is yes and no questions, and a score above 5 suggests depression. It takes on average about 5 to 7 minutes to complete. The Cornell scale, that is used in moderate to severe dementia. That's 19 questions and observations, and this is done in a 2-step format. The provider interviews the caregiver related to behaviors in the week prior to the interview, and then also has a short interview with the patient. The average time to complete this is 30 minutes. Greater than 10 is probable depression, and greater than 18 is definite depression. The USPSF recommends this scale for use for screening for dementia in patients, or screening for depression in patients with dementia. The PHQ we are all very familiar with. It actually comes in a couple different forms. The PHQ-2 is a 2-question screening related to depressed mood, and if that is positive, you should go on to the PHQ-9. Score 3 of higher is likely to elicit a depressive disorder. Patients should be screened with the PHQ-9 if the PHQ-2 is positive. The geriatric anxiety scale, this has many variations. Most common is a 10-question yes or no response, and this is used most commonly in long-term care. The original screening is 30 questions, and those are answered on a 4-point Likert scale. This is a very proven to be a valid tool used to detect anxiety symptoms in dementia patients. The CDC suggests using the BRFSS, the Behavioral Risk Factor Survey, to collect data on mental health of the older adult population. In general, it consists of 3 parts. The core questions are related to mental health and collect data on prevalence of social and emotional support, life satisfaction, and the number of mentally unhealthy days they experience. This information is collected in surveys and used to identify and monitor the needs of the mental health of our aging population. Healthcare providers, especially those practicing in primary care, play a key role in management of the mental health of our seniors and help provide a comprehensive mental health care and foster those supportive environments. Older adults often emphasize that physical complaints over cognitive or mood concerns, and they often report mild or vague symptoms related to depressions and anxieties. Symptoms of depression often overlap with chronic diseases, physical illness, and medication side effects, which is one of the reasons it is underdiagnosed in this population. Evidence-based practice suggests that psychotherapies be the first line of treatment. Treatment of a psychiatric disorder with the goal of reducing symptoms and improving function. There are many different forms of psychotherapy, and a professional should be utilized to analyze which cognitive behavioral therapy, psychotherapy, problem-solving treatment would be best for the patient. Primary care providers are more likely to treat older adults with medication rather than psychotherapy. However, psychotherapy is proven to be evidence-based practice as the best option for this age group. I would enlist the help of a therapist in treating the mental health of this population. Some pharmaceutical options are listed below. However, most are contraindicated in the geriatric population due to their side effects. The combination of pharmacological and psychosocial interventions is the most effective. The next spectrum population is the perinatal and lactation population. 15 to 21% of pregnant and postpartum women will experience a mood or anxiety disorder. Approximately 400,000 mothers in the U.S. experience postpartum depression each year. However, only a small portion of these women are actually identified as depressed by a healthcare provider. Many women, nearly 40 to 80%, experience baby blues in the immediate postpartum period that lasts up to 2 weeks. Anything longer than 2 weeks is to be concerned. Risk factors for postpartum depression include low socioeconomic status, a lower education level, a history of a mental illness, an infant born preterm, exposure to violence during or after the pregnancy, and lack of social support. In the table to your right, you'll see the distinguishing factors between baby blues and major postpartum depression. Screening should be the first step in detecting signs of postpartum depression. A clinical exam is necessary to confirm the diagnosis of a positive screen and develop a plan of care with the client. Each clinical setting is unique, and though the evaluation of mental health resources is limited in some communities, this should be thought of as we approach these assessments. The American College of OBGYN suggests screening for depression and anxiety at least once during the perinatal period. There's a couple different scales that we can use. The go-to scale and the scale most frequently used is the EPDS, the Edinburgh Postnatal Depression Scale. This is a 10-question scale, 10-question screening. Scores above 10 indicate depression, and typically it takes 3 to 5 minutes to complete. Along with that, the PASS, or the perinatal anxiety screening scale, is also used to distinguish the presence of anxiety pre and post pregnancy. During pregnancy, this anxiety may be greater as postpartum depression or perinatal depression is rising, and that may also be affecting the pregnancy outcomes and how that mother will care for that child. The PASS is a 31-question scale: 1 on acute anxiety and adjustment, 2 on worrisomeness, 3 on perfectionism, 4 on social anxiety. Mild to moderate anxiety scores are 21 to 41, and severe anxiety is 42 plus. So to the right here, you'll see a table listing the different languages and different scales used for depression and anxiety screening instruments in the pregnant and breastfeeding woman. Currently, the only mental health illness recognized by the APA associated with pregnancy and the postpartum period is the major postpartum depression. For the diagnosis of postpartum depression to be made, the following symptoms have to be present for 2 weeks, including depressed mood, weight loss, loss of appetite, weight gain, increase in appetite, insomnia, psychomotor agitation, fatigue, loss of energy, inability to focus, suicidal ideations, etc. This can be classified as far as postpartum depression as mild, moderate, and severe, and some may present with psychotic features in full or partial remission, and some may be unspecified. Referral to an experienced psychiatric provider or a therapist for a medication eval is an important step because there are risks in not treating perinatal depression adequately. There are a couple different screening tools we can use, treatment plans. So the woman's preference and the severity of the symptoms should always be taken into consideration. The non-pharmacological will remain the first choice in treating depression and anxiety in the pregnant and the breastfeeding woman. Cognitive behavioral therapy, interpersonal psychosocial therapy, group therapy such as support groups will remain number 1, followed by antidepressant regimen, which is controversial. A referral would be indicated to that to outweigh the risks and benefits of that with the patient. Anxiety is not listed as a DSM-5 recognized anxiety disorder related to the perinatal period. Again, the women's preferences and severity of the symptoms should be taken into account when looking at a treatment option. Non-pharmacological therapies are the best. Relaxation, mindfulness training, cognitive behavioral therapy are listed as number one. Secondarily, pharmacological treatment is possible. However, it's still controversial in pregnancy. SSRIs, SNRIs could be used, and also analytics like diazepam. However, that can cause neonatal lethargy, so it's frequently not used when mothers realize that they have side effects to the unborn child. The mental health of our pediatric population is definitely one that I can see a rising concern in my community. These are just some random facts. 1 in 6 children in the U.S., 2 to 8, have been diagnosed with a mental, behavioral, or developmental disorder. Most common mental disorders include those rated with the greatest childhood morbidity and have an onset in childhood or adolescence. Childhood and adolescence provide critical periods for prevention, early detection, and intervention to promote the child's mental and behavioral health. Risk factors for developing a mental illness during a pediatric or adolescent phase include low socioeconomic status, educational status, poverty status, and toxic stresses placed on the child. Socioeconomic status can impact children of all ages, but disproportionately disadvantaged racial and ethnic minorities have had an increase in maternal deprivation, minority status affecting the family stress, and that significantly contributes to their mental health disparities. Family structures such as single-parent households also have an impact on a child's mental health. Early transition to the adult role placed on these children in the single-family household puts a burden on the child. Third, adverse childhood experiences such as chronic exposure to traumas, stresses, or diseases could negatively affect the child. And finally, the neighborhood that they live in, the social stresses that they have to deal with, including the mental and behavioral health of those around them, put them at a residential segregation, disadvantage, mobility, and violence. Environmental toxicity research shows that prolonged stress, prolonged trauma could impact early brain development and later brain function, and this will affect the child's overall mental health. Children living below the 100th percent of the federally poverty line have a 1 in 5 chance of developing a mental, behavioral, developmental disorder. Diagnosis of ADHD, anxiety, depression become more common as the age of the child increases. Related to assessments and screenings of mental health concerns in the pediatric and adolescent population, you can see from the slide there are an absolute ton of mental health concerns with our pediatric population, and several different assessment tools that can be used under each category. The broadband mental health screen is a screening tool used for children that accompany more than one mental issue, such as depression, anxiety, and it can kind of track patients over time. This includes the DSM-5 online assessment, the PHQ, which you've talked about earlier, the PSC, which is a 17 or 35 question version relating to behavior and attention, and the SDQ, which is a 25 question screen consisting of attention, anxiety, depression, contact with peer relations, and social behaviors. In regards to ADHD, there are several assessments as well. One of them is the Conners scale. There's a short version and a long version. The parents, teachers, and the youth will all do a version, and this assesses for ADHD and any comorbids. The disruptive behavior scale, the DSM-5 online assessment again, the PSC again, and most commonly what I see used in practices around here is the Vanderbilt assessment. This is a 25 to 55 question parent-teacher initial and follow-up version. This assesses for inattention, impulsivity, hyperactive disorders, comorbids, including deficit disorders, OCDs, contact disorders, depression, and anxiety, and that's good for children 6 ages and older. In regards to anxiety, the DSM-5 is still utilized. The GAD-7 the GAD-7, which is something we talked about earlier, the SCARED questionnaire, the PHQ again, and the SCAS, which is a questions about anxiety. It's a version for young children down to 2.5 years old and older children up to 12. In regards to depression, there are several different tools, including the CESDC, the DSM-5 as well, the CADS scale, the PHQ again, and then the ASQ. The ASQ is a 4-question assessment that is usually conducted without parents. This is used mostly in emergency departments and inpatient units in the primary care setting. And then in regards to substance use, substance abuse, there are several different screenings utilized for the pediatric and adolescent population. Those are listed below. The most common is the audit score, which is a 10 screening tool that assesses alcohol consumption, drinking behaviors, and alcohol-related problems. General population screens, this can usually be done with teens. And then finally, the trauma assessment, most commonly conducted, is the CRIES 13. It's a 15-question survey for survivors of trauma, including issues on avoidance, intrusion, psychological arousal. There is a youth version, and this can be used in ages 8 and above. The first thing we have to do as a primary care provider when we do an assessment or screening for a mental health concern in an adolescent or a child is identify what are we going to do with a positive result, and where are we going to be able to send this child for help. Many communities lack mental health care and even lack less in those that can specialize in pediatrics and adolescents. Local mental health resources are obviously very variable, so we must consider telehealth options, especially in absence of resources. And this must be the first thing we think about as a primary care provider when conducting these screenings. Children with childhood mental disorders need behavioral health services, such as services to pinpoint diagnosed conditions, referrals, and additional treatments. The number of providers who can offer these services is definitely going to vary by your geographical location. Follow-up and treatment will vary based on the condition screened for, as well as the access to local mental health. A positive result should be always referred to for a more detailed assessment and diagnosis. Non-pharmacological treatments that include cognitive behavioral therapy, and behavior management, which is parent training, teaching the parents how to manage different behaviors. And then there are a variety of pharmacological treatments. ADHD, which is disruptive behaviors, child behavior therapy will work well. In addition to that, you can have cognitive behavioral therapy or stimulants or non-stimulants. Disruptive behavior therapy is good for depression, anxiety, and PTSD. In regards to pharmacological ADHD, stimulants or non-stimulants, they come in several different forms, such as pills, patches, or liquids. They can include things like Vyvanse and clonidine. Antidepressants for depression include SSRIs, SNRIs, and tricyclic antidepressants can be helpful in treatment of depression, school phobias, panic attacks, panic disorders, bedwetting, eating disorders, OCD, ADHD, etc. That can include Prozac, Zoloft, Paxil, Cymbalta, Effixor, duloxetine, just to name a few. Antipsychotics, the first and second generations can be used. They are helpful in controlling psychotic symptoms, including delusions and hallucinations or disorganized thinking. They're also used to treat irritability in those with autism. These medications can also help with tics and tics in those that are diagnosed with Tourette's disorder, and are also used in severe anxiety and aggressive behavior. First generation antipsychotics include Thortalizidine, haloperidol, Hadol. Second generations include Seroquel, Abilify, Risperdal. Mood stabilizers, these medications are helpful in treating bipolar disorder, severe mood symptoms, and mood swings. They can include Depakote or valproic acid and Lamictal. Anti-anxiety medications, SSRIs, are used to treat anxiety in children and adolescents, and they're described above in the antidepressant section. There are also other medications used to treat anxiety in adults, but these medications are rarely used in children due to the brief treatment of severe anxiety in children. They can commonly include benzos, antihistamines, and antipsychotics. Benzos would be like a Xanax or Ativan. An antihistamine would be a Benadryl or a Vistarol. And atypical anti-anxiety medications would be Ambien or Buspar. Finally, sleep as a mental health disorder. A variety of medications can be used for a short period to help with sleep. This could include melatonin, trazodone, Ambien, Lunesta, and Benadryl as needed. Again, non-pharmacological therapies is the first line of treatment, and together non-pharm and pharm will work together to create your best result. The LGBTQ community is our next community. The LGBTQ adults are 2 times more to experience a mental health condition compared to their heterosexual counterparts. Transgender individuals are 4 times more likely to experience a mental health condition. LGBTQ youth are 2 times as likely to express feelings of sadness, hopelessness, and consideration of suicide or attempted suicide. Risk factors for an increase in the mental health of this population include coming out at a younger age, receiving rejection from family and loved ones that they once loved and trust, trauma, substance use, homelessness, and obviously suicide. This can have a negative impact on mental health, particularly those who are not in supportive environments. Coming out is very difficult and can be a traumatic experience, and being able to cope with rejection or something on a personal level like that from one's close family or friends or within your work environment is very taxing on the mental health of this population. 40% of the LGBTQ community have experienced rejection from an immediate family member or close friend after coming out. The LGBTQ community faces many forms of discrimination, including stereotyping, labeling, denial of opportunity, verbal, mental, and physical abuse related to themselves. Substance misuse and overuse is a way they can cope. However, options like self-meditation are preferred. If a significant concern for family of the community, adults are nearly twice as likely, LGBTQ adults are nearly twice as likely as heterosexual adults to experience a substance use disorder due to the frequency of using this coping mechanism to deal with the trauma and the rejection. The youth and the young adults have 120% higher risk of experiencing homelessness, often related to family rejection and sexual orientation. Many people in this community will struggle in silence, and they face worse healthcare outcomes from it. The LGBTQ community is at higher risk than the heterosexual community for suicidal thoughts, suicidal attempts. High school students who identified as LGBTQ are 4 times more likely to have attempted suicide in their high school days than their heterosexual counterparts. 40% of the transgender adult population have attempted suicide in their life, compared to 5% of the U.S. general population. There are a couple assessment tools and screenings we can do when conducting mental health screens. One that I found really interesting during my research was the MHA screening program, which is an online program. It's free, it's anonymous, it's confidential, and it allows people to explore their mental health concerns without physically having to sit down with a person and identify themselves as LGBTQ and just kind of see where they lie, truly just in a non-biased, anonymous format. That availability is at the website listed on the slide. Other screening tools include the PHQ-2 followed by the PHQ-9 as well as the GAD-7 for anxiety. Taking the stigma out of trying to find a provider who understands the LGBT community in the preferred pronouns that are used in that community is incredibly critical for patients to feel safe. And they have to feel safe in order to come into your office to complete an assessment or screening, which is why I kind of found this MHA screening to be a very good option for those who know possibly that they have, something going on that needs to be addressed, and the screening will take them through, like, okay, these are the steps, this is what we think. And most of the time, according to the research provided by this screening, that they take that information to a provider, that it allows them to find a provider who's skilled in the LGBTQ community and mental health and refer them to them. So then they can take that information there and say, okay, this is what I got on this screen. I need help. What can we talk about it? The screening tool can be used by the general public, any individual. It doesn't matter if they identify as LGBTQ, straight, whatever. But this allows them nearly 2 times as likely to take a mental health screen in comparison to coming into a primary care office and actually genuinely telling you the truth related to their sexual orientation or their current mental health state. Number one step in creating a treatment plan for an LGBTQ patient is providing an inclusive environment. They don't feel comfortable with the LGBT community disclosing sexual identity and gender identities, but part of a comprehensive mental assessment for the youth is asking about that sexual orientation and gender identity. As identifying as an LGBT community member, that's a standalone indicator for trauma and mental health risks, especially those of sexual minority and gender diversity. Those, however, who disclose their sexual orientation often have fewer psychiatric problems than those who do not. Mental health education specific to the LGBTQ community is hard to find. Most frequently, it is utilized via telehealth visits with trained professionals. However, I do believe the general medical nursing population has definitely been getting better at this inclusion initiative and really understanding where everybody's coming from to kind of break down those barriers. Removing barriers to treatment, such as the stigma around receiving mental health care. And generally, you will treat as adults as you would adults, and adolescents in terms of pharmacological treatment. There is no difference in how one should treat pharmacologically based on your sexual orientation, your gender, anything like that. That should not affect how pharmacologically we treat the different mental health concerns in these patients. As far as non-pharmacological therapy, there are several different psychotherapies, such as cognitive behavioral therapy, group therapies, things like that, that can help these populations. Most often you find the group therapies to be most helpful, but they are difficult to find, especially in the rural populations. Many LGBT individuals have reported negative experiences with mental health care, and that might be contributing towards their reluctance to seek treatment. Migrant workers and the immigrant population. In 2015, the U.S. immigrant population was 43.3 million, and that's 13.5% of the total U.S. population. Immigrants and migrant workers are less likely to access mental health treatment when compared to their U.S. counterparts. The migration process by which an individual arrives in the country will have a great impact on their mental health. There can be various traumatic experiences, including family separation, sexual physical trauma, and exposure to violence during this transition. There is often a lack of social support that can lead in dysfunctional behaviors, such as substance abuse. Active consistently hiding or trying to hide their status and remain hypervigilant of their surroundings can affect their mental health. The age of the migration and the loss of identity and self-worth related to where they came from and where they are now can definitely impact an overall mental health from child to adult. Risk factors related to increase in mental health concerns among this population include traumatic events, the loss of the social support, and the loss of identity. There are numerous screening tools that have been deployed or used by experts in refugee mental health. And when accessing the usability of these tools, it's important to remember the migrant workers or immigrants' literacy level and what their first language is of choice. Many of these assessments and screenings you see listed on this slide come in a variety of languages. Usually over 5+ different languages, including your Spanish and your Vietnamese. The first one is the broad screening, which is the refugee health screener. This is a 15-question screening, screens for anxiety, depression, PTSD, adjustment disorder, coping, a referral for a positive score over 5. The Harvard Trauma Questionnaire, this inquires about trauma and trauma symptoms. And that's related to PTSD. The primary care provider can also conduct the PTSD screen, which is the DSM-5 preferred screen. It's 6 questions, and it's available for anybody exposed to trauma. If they answer positive to question number 1, proceed to the rest of the questions to indicate the level of trauma within that person's mindset. In regards to depression, we've talked about the PHQ-2 and the PHQ-9. This is available in many different languages, and it is a gold standard across the board for adult depression screenings. Anxiety and depression, the Hopkins symptom checker, that's 25 questions, 10 for anxiety and 15 for depression. Again, comes in a variety of languages and easy to understand. And then finally, related to alcohol dependence, the CAGE questionnaire can be utilized to assess for any substance use problems within the migrant worker immigrant population. There's a good portion of the migrant worker immigrant population that will deny referral to mental health professionals just due to the stigma and the surrounded by mental health. So a primary care provider must be ready to handle mental health concerns in this population and know what to do with a positive screen. A good way to start with a treatment plan here is to eliminate the common barriers for follow-up. This would include the stigma of receiving mental health care, a lack of understanding, a logistical barrier related to transportation to and from said clinic, and then the language barrier. It's really important to try to meet these people on their level as far as their language, talk in simple terms, and if possible, use some type of translation device so that you can better understand and have a conversation with them to get the most out of that experience. Refer for appropriate non-pharm therapy as indicated, which includes cognitive behavioral therapy and other psychotherapies. Again, remembering that they're less likely to actually receive these therapies due to the stigma surrounding them. Removing barriers to treatment, such as the stigma. And again, you're treating adults as adults and adolescents as adolescents. However, how you approach this education and the education related to mental health, you just have to be more culturally competent and use the correct language and really educate on the importance of why this matters to them. The next couple slides are the references that I utilize to complete this PowerPoint. There's several good websites listed here, so if you have a chance, go ahead and take a look at a few of those. My favorite being that MHA website for the LGBTQ community, or any community really looking for anonymous way to really hone in on where their mental health lies in a way that they can seek follow-up as they see fit. Thank you.